Also, I can't speak enough about how important it is to have accurate and timely data. You have to give the feedback. We were meeting weekly in that PCI task force, and when we started getting better, we were meeting, biweekly and then monthly. Depending on what your certain situation is, you might need your data on a daily basis or even more, or you can maybe wait quarterly, depending on what you need. But you need good data. You need to make sure that the right people get the data and that it's used to make important changes, and then checked again after that to make sure that the changes you make actually had the effect that you were trying to get. And then how do you do it? You have to hardwire the critical pathways and processes, and that's the hard work. All of those things that I was talking about required that we had processes in place. We had an army of nurses, quality nurses, that were always on the floors, checking the charts, checking to make sure everything was done, that the patients would not be discharged before all of the indicators were met. Also, we had for the code hard process, we had special forms. We had a special procedure for evaluating the data. Everything had forms and processes. Everyone was in service on them. It's really a lot of work, but you have to do it. And then you have to have the confidence that you are going to meet your goal. You cannot have people on your team who don't believe that you can get there. The naysayers. You need to either convert them or ask them to go somewhere else. But you need a full team of very dedicated, confident, enthusiastic people who believe you can reach these goals. Okay? And I tell you, when we did that PCI task force, no one now can tell me anything about what can't be done. When I saw that happen, I said, okay, this is it. Don't ever come to me telling me something can't be done. So that's the inpatient piece. Now I'll talk a little bit about the outpatient. For the outpatient piece, we wanted to make sure we had the continuum of care. And so what we did was we took our disease management program and souped it up as much as we could. And this is Maria. She's a disease management nurse who we morphed into what we call a cardiac care manager. And so she would meet the patients at the bedside. The patients we felt the most vulnerable, the ones who don't have insurance, she would meet them at the bedside. She would explain to them what was going to happen. They came out of the hospital, and she helped them to go through the eligibility process. She would take her laptop at the bedside and actually sign the patients up to have their eligibility appointments and to come to our, make appointment to come to our clinics. And she wouldn't just leave it there. She served as a liaison for the patient the whole way through the process. So if a patient didn't know how to get their medications and they weren't comfortable, they would call Maria. If the patient didn't know how to get a referral, they would call Maria. If the patient was being evicted, they would call Maria. If the patient ended up in prison, they would call Maria. If the patient, had multiple challenges with transportation, they would call Maria. So Maria became the liaison for the patients, and that function, you see it in multiple different places. So we had a cardiac care manager here, but you've probably heard of the term navigator. That's become a big buzzword now, navigator. People who are out there working with the patients to keep them in compliance with their care plan, to not let them fall through the cracks, to really be there for them, people they can trust, people they feel comfortable with. And Maria served that. Maria is bilingual, so she was able to communicate with all our patients. And this lady was a patient that had suffered a heart attack and was discharged into our system and did very well. So just to give you a sense for Memorial's commitment to community health and to give you some idea of like what type of framework we're talking about that these patients are being discharged into, this is a diagram that I made after I saw Wagner's chronic care model, which I have a picture of, a diagram of at the end. But I love that model, and I thought, well, what do we have? What components do we have? So this is an ever-changing model. As we add things or change things, we update this, and it's something that I think that you guys are developing your own model. So it'll be interesting to see what model you have. But over here, if you start out in the inpatient side, let's see right here, we actually have in the inpatient side a group of hospitalists that are dedicated to taking care of uninsured patients in the hospital setting, and so those patients communicate with our outpatient internal medicine and family physicians in our clinic system. So that's really important because from the very beginning, if the patient's in the hospital, there's that potential for that communication. The patients also have access to specialists and intensivists that the insured patients, same set of physicians that the insured patients use. We have the ED, which everybody knows is unfortunately overutilized sometimes by these patients, and all these outpatient services. And then here's primary care. This is my department. And we have adult, pediatric, OBGYN clinics. We have 4 locations that are strategically located in areas where they're underserved, considered underserved areas, where patients feel comfortable and where their bus routes go. That's very important. We don't put a clinic where we don't have a good bus route. And when we have overflow, we actually started this program several years ago where we have private physicians in the community who are willing to be primary care physicians for our patients. And they take panels of patients and we pay them per member per month, capitated amount. So it's just like those patients are going to the office just like any other insured patient. And these patients, all these patients get pharmacy. We're very aggressive at trying to find cost-effective ways of dealing with pharmacy. We use the federal government's 340B program as well as the pharmaceutical companies' patient assistance programs. We save about $5 million a year just by being very aggressive with that. But the patients get great medications. Specialists, we have a good specialist network. We pay them fee-for-service. And we have this disease management program, which I talked about, behavioral health services and social services. So we have a nice integrated framework foundation there. What's really cool about our system is this community-based healthcare out here, and you guys seem like you're doing a lot of that already. So we have a lot of partnerships in the community. We work with the Department of Health. We work with the county Health and Human Services departments. We work with churches, with Hispanic Unity. Anyone that will partner with us, we work with them. And we have mobile units to go out, an adult mobile unit and a pediatric mobile unit that go out into the really hard to reach areas where people are in the community who may not even know we exist. They may not even know what services we have, or they may know but they don't trust institutions. So we have to go out to where they're at. And we have a wonderfully caring physician and nurse practitioner and staff that go out into the community and really make the patients feel comfortable. They do health screenings, they do education about health, as well as education about what services our healthcare system provides. And they try to encourage those patients to come into our healthcare system where they will get care under the more traditional model. We don't like to give all the care out in the community because we feel like that's shortchanging the patients. We also have a couple of clinics in homeless shelters, and we do a lot of health fairs. So basically, Maria is the cardiac care manager that is the link, the bridge between the inpatient and the outpatient services that the patient will get. Okay, so the successes of our outpatient program were many. We did accomplish that smooth transition. We did get continuity of cardiac care in the outpatient setting. In addition, the patients got comprehensive primary care. And they increased their compliance with the medical care because anytime they ran into to challenges, they would contact Maria. We also gave them effective patient education, which when we did an independent study afterwards, we found that the patients really were knowledgeable about their disease as well as their medications, so the education was really working. And the assistance navigating the healthcare system, linking them to social services and just having that telephone contact with the cardiac care manager. And we had high patient satisfaction. That's all the good stuff. It's great. Now, challenges. What we observed that was very concerning to us was we had a lot of no-shows. All of the work we were doing at the bedside and helping the patient get into the primary care setting, we still had 60% no-show for the first visit. So it required another 2 phone calls and appointments to try and get the patient to just get there, get to the clinic. And after about 3 tries, we ended up with 80% compliance. So it was a lot of hard work just getting the patient there. They also were incomplete with their adherence to their medical plan. We also saw about 25% of our patients in this program had alcohol and or drug abuse issues that interfered with their compliance.